In 2014, the SGO came out with a statement that all patients with ovarian cancer should be tested for both BRCA1 and BRCA2 germline mutations. And this is really important because we know about 30% of patients with ovarian cancer do not have a first-degree relative or someone close in their family with a cancer history, and approximately 35% of patients with germline mutations don't develop ovarian cancer until after the age of 60. And it's really important that patients undergo this testing because it helps to inform relatives and other family members so that they can undergo testing themselves. It allows for patients to undergo risk reduction surgery, if appropriate, and it also opens up new therapies for patients. In terms of HRD testing, we know that patients that receive PARP inhibitors tend to have a greater response if they have a germline BRCA mutation. And the efficacy decreases somewhat as you go to somatic mutation tumors that are BRCA negative but HRD positive, followed by wild type tumors that are HRD negative. So HRD testing allows us to, in some instances, better inform groups of patients as to what kind of response that they may have while on therapy. So if we look at the NOVA trial, which evaluated niraparib versus placebo in patients with platinum-sensitive recurrent disease, patients that received niraparib in the maintenance setting had a significantly increased progression-free survival as compared to patients who received placebo. Now, the improvement, or the PFS, was greatest for patients who had a germline mutation and a somatic BRCA mutation. However, all subgroups evaluated, including patients that were BRCA wild type and HRD negative, had a significant improvement in progression-free survival. So this really opened the door and allowed a broad label for PARP inhibitors in the maintenance setting, so that patients who wanted or who want this drug in the maintenance setting don't have to undergo germline or somatic testing or HRD testing to be eligible to receive it. I think there are a couple of places for HRD testing clinically. The first, again, is to inform patients of what kind of response that they may have while on the drug. And in addition, it helps in the treatment setting for clinicians to be able to know which patients will qualify for a drug. So in the treatment setting, patients are eligible for olaparib if they've had greater than or equal to 3 lines of treatment and have a germline BRCA mutation. The indications are a little bit different for rucaparib. So rucaparib is FDA approved for patients with greater than or equal to 2 lines of previous treatment, and they can have a germline or a somatic BRCA mutation. So if a patient is germline negative and you want to put them on a PARP inhibitor for treatment, then testing their tumor for somatic mutation or HRD positivity would make sense to see if they would qualify for the rucaparib agent. Again, in the maintenance setting, it's not necessary for patients to undergo HRD testing, but it can inform patients to expectations regarding outcome. Now, HRD is really good at giving us an idea of how a group of patients is going to respond to a PARP inhibitor, but it's really not adequately sensitive to be able to inform an individual patient as to how they're going to respond. So it's just really important to keep that in mind. In terms of coverage, I think it's important to try to get coverage through insurance for these tests off of clinical trial. But if that's not possible, companies such as Myriad have programs to help cover the cost for patients who aren't able to afford the testing when insurance doesn't cover it.